Limbic system is an incredibly important area to understand if you're going to work with patients with neurological injury. The thing that you need to remember about the limbic system is it's what moves you. MOVE is an acronym that stands for memory and motivation, olfaction, visceral drive, and emotion. The exact structures that are responsible for forming the limbic system are debatable. There are some that are absolutely essential, such as the amygdala. Everyone agrees that the amygdala is part of the limbic system. However, the others are relatively unknown. As far as the memory and motivation aspect of the limbic system, memory is attention and retrieval, and it only deals with declarative learning, not procedural learning. We'll talk about the difference between those two again a little bit later in the presentation. Limbic system also deals very strongly with motivation. Motivation is the desire to learn or try or benefit from the environment. This is going to be very important when trying to come up with goals for your patients. You need to know what motivates the patient, not what you want the patient to be able to do. For example, if you want the patient to be able to walk across the room and the patient has no desire to walk across the room, that's not going to be a very good goal for that patient. However, if the patient wants to be able to put his pants on or her pants on standing up, even though that's not a goal that you would typically consider for the patient, if that's what they're motivated to do, that's what you have to choose as their goal in order for them to be able to work and learn what you're teaching them. Another important part of the limbic system that you can use when working with patients, specifically in a coma, is olfaction. And it turns out that the sense of smell is the only sensory system that doesn't go through the thalamus before it hits the cerebral cortex. This is a very useful sense to use. You always want your patients to like you and do things for you. But if you can imagine a patient in the coma, a lot of times therapists or even doctors will use something like smelling salts to arouse the patient from their coma. This is pretty nasty smelling stuff. Another possibility would be to use a very pleasant scent, possibly a perfume or a favorite perfume of the person in the coma, or even scent of chocolate chip cookie or vanilla or cinnamon, something that the patient might enjoy. Since they're receiving this scent through olfaction, it's actually going through their limbic system. It's part of their limbic system. So you're getting the person to like you and you're motivating them in a positive manner. The V in the acronym MOVE stands for visceral drive. Visceral drive is thirst, hunger, temperature regulation. A lot has to do with the endocrine system. It includes your sympathetic and parasympathetic reactions, your hypothalamic regulation over your autoimmune system, and your peripheral autonomic nervous system's responses to limbic functions. An example of this would be fear. If the patient is particularly afraid, then the limbic system is going to be activated, and this activation could result in peripheral nervous system changes resulting in, say, pupil constriction or sweating or shaking, for example. So the limbic system has a very strong connection with how your patient's feeling as far as their emotions are concerned. And the E for MOVE is feelings and attitude, or your emotions, your self-concept and worth, body image, tonal responses affected by the limbic descending pathways, your attitude, your social skills, and your opinions. All of these things encompass all the different neuroanatomical levels of function at different levels and are very important for motivating patients to work with you. The limbic system has a couple of continuums that are important to note. The first is F squared ARV. F squared ARV stands for fear, frustration, anger, rage, and violence or withdrawal. This is an important continuum to remember when you're working with a patient who has any sort of brain injury. All of these things come from the amygdala circuitry, and what happens is that if a patient becomes frustrated or particularly afraid, they can rapidly progress to anger, turning into rage, which ends up with you getting slapped in the face. It happens. It happens very quickly. Most people without brain injury have a lot of control over this particular continuum, and it also depends on the person. I mean, some people you can set off pretty easily. I'm sure you know people like that. Other people you have to really provoke before they're going to get angry. But realize that in patients who have had a brain injury, if they become frustrated or if they are very afraid, they will very quickly run through the fear, anger, rage, violence stages, and it is a very, very difficult situation to get under control. What you need to know as a therapist is that this continuum exists, and when working with a patient with brain injury, you really have to begin to notice their feelings. Are they particularly afraid? Are they getting frustrated? Kind of watch them, because you don't want to have them go down this slippery slope too quickly. Another limbic continuum worth noting is called General Adaptation Syndrome, or GAS. Ordinarily, stress to a person leads to a sympathetic response. This response should be followed by a parasympathetic response, which allows the person to return back to a normal state. If this happens acutely and turns right back off again, this is fine. But what can happen is a person can be stuck in one portion of the cycle or the other. An example of this would be neurostorms for individuals with head trauma. In this case, any kind of stress leads to a sympathetic response, and that patient is stuck in a sympathetic fight or flight state of arousal. Alternatively, the person may be stuck in a parasympathetic response. In this particular situation, the person is not able to be aroused or to be motivated to do anything. They're simply flat and don't want to do anything, aren't really able to do anything because their body is stuck in that parasympathetic state. An important takeaway message from this presentation is that memory and motor learning involve the limbic system. The structures that are involved with declarative learning and memory are the hippocampus and the amygdala. If both the hippocampus and the amygdala are removed bilaterally, amnesia is global. So that means a person won't be able to remember past events, nor will they be able to form new memories in the future. They have patients with any kind of problem to the hippocampus are going to have difficulty forming long-term memories. Their short-term memory can be as short as 10 seconds, which makes it interesting to work with this patient population, to say the least. The limbic system is involved in declarative memory. It actually creates a chemical bond that promotes storage of memory, and it is absolutely necessary for subsequent recognition and recall of declarative information. However, in addition to declarative memory, we also have procedural or motor memory. Motor memory involves simply sensory input that synapses in the thalamus and finally into the sensory cortex. It's processed for somatosensory map. The programming of information is then relayed to the motor cortex. Basal ganglia are required. Cerebellum is required for postural adaptations and timing and coordination throughout the sequence. And the storage and retrieval of motor memories, which at this time, over and over with practice, become semi-automatic, occur throughout the motor control system. The limbic system is not necessary for procedural memory to occur. Having said that, if you place an emotional value on the task, then the limbic system is necessary. An example of using an emotional component would be if you angered the patient. If the patient was very angry, or if the patient was very fearful, or something they were doing made them particularly sad, then no procedural learning would occur. You would be going through the declarative memory system. Because you've activated the limbic system, just by placing an emotional component on the task, that means you've lost the ability to learn pure procedural memory. Now, why is this important? This is very important clinically because there are patients who have had some sort of brain injury, and one of the neuroanatomical levels of function is affected, which means that the limbic system could possibly be affected, and the patient is able to do things functionally, however, they lack the cognition necessary to do things safely. Oh gosh, examples of patients that I've seen with a lack of safety because of cognition would be not knowing how to use objects. For example, a patient trying to brush their teeth with a razor. Happens. They see the razor, they know they put it in their hand, they put it up to their face somehow, but they forget and actually try and brush their teeth with it. So they're always going to require supervision. Even though if we're given a toothbrush, they can brush their teeth without a problem. They don't know how to do it safely. If you give them another object, they're going to try and use it to brush their teeth. So they're always going to need that supervision. If a person lacks this kind of cognition, or if they have something wrong with hippocampus or amygdala hippocampus in particular, then they're going to need supervision because they're not going to remember what to do with objects. You can teach them to brush their teeth until it becomes semi-automatic, or you can teach them to walk or go up and down steps safely, but you're always going to have to watch them because they're going to need supervision for problem solving and safety.